Welcome. This is lecture 76 of this series. This series of lectures is based on my book Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I am Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. You can find the book on Amazon at the link below. We have reached the last chapter of my book. This chapter is very important. It is intravenous fluids, chemistry, and indications. Today, part 1 is introduction and overview. So we're going to set the stage to what's going to come in the next 4 or 5 lectures. It is really hard to think of a medical discipline where intravenous fluids are not utilized. So you really need to know this information regardless of what specialty you may be practicing. There are so many mistakes made daily when it comes to intravenous fluids, although the general principles, as you are going to see, are very simple. So let's get started. Intravenous fluids, not surprisingly, are the most used drugs in hospitalized patients. This is critical to all medical disciplines. Normal saline, also known as isotonic saline or 0.9% saline or 0.9% normal saline, is the most utilized of all intravenous fluids. Why is that? It expands the intravascular compartment. 1/4 goes intravascularly. The 3/4, the 3 remaining quarters, go into the interstitial space. The proper use of intravenous fluids is very important because different medical scenarios necessitate different intravenous fluids. Intravenous fluids are drugs. They have different half-lives. They have different intravascular volume expansion, and they have different cost. The most utilized intravenous fluids are crystalloids, although colloids are sometimes used. Why do we use crystalloids more? Well, they're readily available and they're cheap. Colloids have advantages in patients with hemorrhage or shock. They remain in the intravascular space for a long while unless there is a leak. This will help in increasing blood pressure prior to blood administration. Colloids are very helpful in severe hypoglobulinemia or in cases of burns. You have human albumin. This is by far the most used colloid. It's available as 5%, 20%, 25% solution depending on where you are, and it remains intravascularly unless there is a capillary leak. In hospitalized patients, we want to provide adequate and timely resuscitation with intravenous fluids. Now, we want to avoid using large volumes of isotonic saline because this can lead to hypervolemia, hypernatremia, hyperchloremia, even non-anion gap metabolic acidosis and hypokalemia, as we shall see. The use of balanced intravenous solutions has been advocated to avoid some of these complications. Also, we'll detail that later. Now, these are some of the general principles. If you have someone who has normal sodium or normonatremic with volume depletion, you can go either with isotonic saline, 0.9 saline, or lactated ringer, also known as Ringer's lactate, LR. Patients who are volume depleted and hypernatremic, well, you give them half normal saline or 0.45 normal saline, or D5W, which is 5% dextrose in water. However, even if the patient is hypernatremic, if they are hypotensive, you still have to give isotonic saline or LR because the priority is to restore the effective intraarterial volume. Now then, once the patient is adequately resuscitated, you can switch to a hypotonic solution. Like we said, if we give large volume of isotonic saline, we can have hypernatremia, hyperchloremia, non-anion gap metabolic acidosis, and hypokalemia. Obviously, this fluid has no potassium. After initial fluid resuscitation, many times you have to add potassium to the initial intravenous fluids. Some other patients are switched to a more hypotonic intravenous solution. A prime example is someone with diabetic ketoacidosis. Usually in the emergency room, they are given 2 to 3 liters of 0.9 normal saline. Then per protocol, they're switched to D5 0.45 normal saline. This way you avoid hypernatremia, and the D5 will help you because you are giving the insulin intravenously, so you do not get hypoglycemia. With prolonged administration of isotonic saline, other electrolytes will have to be replaced, not just potassium. You have to check magnesium, calcium, and phosphate and replace whatever needed replacement. You can add those solutions to 0.9 saline, or you can replace them separately. Lactic acidosis is seen in many patients with hypovolemic shock. These patients are given isotonic saline. This improves their hemodynamics, oxygenation, and improves the lactic acidosis. Usually we don't give sodium bicarbonate solutions unless arterial pH is less than 7.2. Actually, there is not a single study in humans showing that administration of sodium bicarbonate in metabolic acidosis improves survival. Why is that? When you give sodium bicarbonate, you increase the production of carbon dioxide, and that increases intracellular acidosis. So don't give it unless pH is less than 7.2. For example, patients with diabetic ketoacidosis are almost never given sodium bicarbonate. Once the ketoacidosis is corrected, you are going to have regeneration of the bicarbonate. So if you had given bicarbonate already, you are going to end up with metabolic alkalosis. Now we have colloid solutions, like I said, human albumin 5%, 20%, 25%. Much less commonly used is heta starch, 6%, hydroxyethyl starch. Those solutions have large molecules, okay? So they increase the plasma oncotic pressure and remain in the intravascular compartment unless there is a capillary leak, as in systemic inflammation, as in multisystem organ failure. There is a big debate, colloid versus crystalloids. Colloid solutions are expensive, so if we take 100 ml of albumin, 20% to 25%, it costs $109. Now, if we take 100 ml of isotonic saline, the cost is 10 cents, so huge difference. 5% albumin costs about $16. Now, the price differs between pharmacies. Now, I'm going to mention some of these studies quickly, but we'll discuss them in detail in later lectures. The saline versus albumin fluid evaluation, or SAFE study, found no difference in outcome at 28 days between 4% albumin versus isotonic saline for fluid resuscitation in 7,000 patients in multiple medical and surgical intensive care units. A meta-analysis of 55 studies showed no effect of albumin on mortality when compared to crystalloid solutions in critically ill patients. What about balanced solutions versus crystalloids? Now, observational studies have raised concerns regarding the use of large volumes. Now I want to emphasize here large volumes of isotonic saline for resuscitation, and it was suggested that balanced crystalloid solutions are used as alternatives. Now, balanced solutions, though, are associated with hypoosmolality, hyperkalemia, and metabolic alkalosis. Now, here briefly, I'm going to mention this salted study. Again, in later lectures, we'll detail it. The saline against lactated ringer or Plasma-Lyte in emergency department, salted, trial found no difference in hospital-free days in non-critically ill patients treated in the emergency department with either saline or balanced crystalloids. We'll detail other differences later. Let's discuss the 4Ds of intravenous fluid therapy. Intravenous fluids are drugs, so we have to know the indication, the duration of treatment. The 4Ds of intravenous fluid therapy are drug selection. Which intravenous fluids should we use? Dosing, how much? Duration, how long? And then de-escalation. At some point, you have to turn the rate down and eventually stop the intravenous fluids. Now, The main indications to give intravenous fluids are fluid resuscitation, okay, someone with low blood pressure, you want to give them fluids, or replacement, okay, they've lost 2 liters due to vomiting or diarrhea, so you give them that much back. Maintenance, someone in the hospital, they're not eating, you give them maintenance fluids. Now, someone who is critically ill and needs resuscitation, the therapy has 4 phases. The initial phase is resuscitation. So someone hypotensive, you want to stabilize hemodynamics, so you give them fluids, usually 0.9 saline or LR. Then optimization, you want to optimize the treatment. Now their blood pressure is good, so you want to give them the correct fluid. So initially you gave 0.9 saline, but now they're hypernatremic, so you want to give maybe 0.45 normal saline. Then stabilization, you want to make sure that they stay stable, okay? We're past resuscitation, we're past optimization. We want to keep their blood pressure stable, their hemodynamics stable. We are replacing whatever is lost. And finally, de-escalation or evacuation. At some point, like I said, you have to turn the rate down and eventually stop the intravenous fluids. There is no shortage of clinical trials when it comes to intravenous fluids. So many studies when I was researching this topic for my book, and all these studies are in big journals, New England Journal of Medicine, JAMA, etc. Now, when we review these studies, we have to know the indication of the intravenous fluids, what population it was used, what phase of treatment. Otherwise, comparing these studies becomes meaningless. We have to know, is this study in non-critically ill patients? Is this study in emergency department patients? Is it in someone in a surgical critical unit, in a medical critical care unit? Are the patients in shock? We have to know the indication and the phase of the treatment. Is it during the resuscitation, optimization, stabilization, de-escalation, etc.? Like we said, initially we use isotonic saline or LR for resuscitation. Then, during the optimization stabilization, we're going to use maybe a hypotonic solution, 0.45, to avoid hypernatremia. Maybe we need to add potassium or magnesium or phosphorus, like we said. In the de-escalation, we're turning the rate down. Then we're discontinuing the fluids. Many times we have to use diuretics because the patients now are hypervolemic. In some cases, when the patient is not responsive to diuretics, we have to use renal replacement therapy. We have to dialyze some patients. So we have to know the setting of each study. Let's say a word or two about the PICARD study, analysis of the program to improve care in acute renal disease, or the PICARD study revealed that critically ill patients with fluid overload and acute kidney injury are significantly less likely to recover kidney function. So we don't need to flood patients with fluids, okay? Give them what they need, but don't be overzealous. In this study, fluid overload was defined as over 10% accumulation of fluids. Fluid overload at the time of acute kidney injury diagnosis and renal replacement therapy initiation increased mortality at 30 days, 37 versus 25%, and 60 days, 46 versus 32%. P-value was significant. Now, another study, a retrospective cohort study, also found increased mortality in septic patients with fluid overload, with and without acute kidney injury and chronic kidney disease. These issues are debated constantly. There are always studies. Bottom line is, give fluids, give them what they need, but don't overdo it. I'm going to end here. We'll continue this interesting discussion in the next lecture. See you then.